Okay, good morning, everyone. We are going to go ahead and get started today. I just want to say thank you for joining us. We are very excited to have Claire Davis and Lori Kohler with us today to speak on the medication administration rule and nursing services. So I just want to extend a thank you to them. I am also very glad and excited that you all have decided to join us today. Just for your own reference and a little bit of information, this is one of our webinars that has had the highest registration numbers. So from what I can tell, this is a topic that everyone wants to learn about and everyone is willing to take the time out of their day to expand their knowledge. So thank you for that. We appreciate you for your time with this topic. So today, if you are joining us as a support coordinator for credit, for your continuing education credit, as always, this is a presentation that has an assessment at the end of it, and all of the assessment information will be provided at the conclusion of the training. So if you are here for that, please be sure you stay for the entire training to receive your information to access the test. Also, on this training, we have some additional materials. So if you take the moment to look at your GoToWebinar control panel, and towards the bottom, there's a section titled Handouts. There are 4 PDF files attached to the webinar. So please take the time, download those materials. They will be referenced through the presentation, but they are also materials that will help you in the future. So please make sure you have those available to you. If you have trouble finding those materials, we will also be putting them on the website along with the presentation this afternoon. So make sure to look there if for some reason your download is not working from the webinar itself. We also have poll questions today. So if you joined us last month and experienced the interaction with poll questions, we are going to do that again today. So throughout the presentation, we might pause, put a question up on the screen. We are asking for you to please participate. These are a little bit of a knowledge check throughout the presentation. So we'd like to know where you are in your understanding of the information we are providing. So please be aware that those might pop up. We will definitely tell you guys, hey, the question's coming, and we'll also share the results. We'll share with you how people answered and what some of the common thoughts about the questions are. So I'd say it's time to get started. So today we have Claire Davis and we have Lori Kohler. They are here to speak on the medication administration rule and nursing services. So our first speaker today, Lori, I'm going to pass it over to you. Thank you.
Okay. Good morning, everybody. And Elizabeth, I believe we have a poll question before the first slide. Is that correct?
Yes, ma'am, we do.
Excellent. Go for it.
Okay, so at this point, you should be seeing a poll question up on your screen. The question is, I have a current authorization for medication administration in my files for. So please pick the percentage that is closest to you and your caseload. And I'll leave it up just for a few moments. Okay, it looks like we have a good amount of people responding. I'm going to go ahead and close this and share with everyone. So Lori, are you able to see the results of the poll question?
I am. I'm really glad you are all here for this presentation in this case. Yes, this is a very important form. And the reason it's important is because it's one of what we would call the foundational forms for Rule 65G7. So we're going to talk about it for a little bit, and we'll go from there. You can just go on to the first slide, Elizabeth. Next slide.
There we go.
Okay. 65G7 is a rule that was first promulgated or adopted back in 2008. But we just had it, well, we renewed it, made a bunch of changes to it, and it came back out in July 1st of 2019. There are some changes to the rule that really do impact waiver support coordinators. And the requirements of the rule really have an impact on what services a client receives and where those services can be provided. The authorization for medication administration that we were just asking you about, it is required for all clients served by APD. It's a required form. And it documents the client's level of ability and their need for assistance with medication. We also require an informed consent for medication administration if unlicensed providers are going to be helping the client with medication. By signing it, the client and the legal guardian or representative, show that they know that the provider is not professionally licensed to give meds. Next slide. This is the authorization for medication administration. It is one of the forms that Elizabeth has provided to you. The rule 65G7.002A, if you need to find it in the rule, does tell us that the current authorization form must be maintained in its current place of residence with a copy of the form in the client's record. You, the WSC, are responsible for assuring that all providers that assist a client with medications have an up-to-date copy of this authorization. It is the job of the waiver support coordinator to maintain the authorization, commonly called the auth, so that they can send any new information out to any provider that might be needing to assist the client with medications. If a provider goes with a client to the doctor and a new authorization is signed, they have to provide that document to you. And just for your own knowledge, know that the authorization is updated annually. Every single year it's updated. So every single year you should be looking for a new auth. If it's done, if the group home is working on it and they do it because they take the client to the doctor, if the family does it because they have in-home services and those people have to be med trained, whoever has it really has to provide you, any provider that has it anyway, has to provide you with a copy of it. And it's something you should be asking for. Next slide. I have heard since that new rule came out that there's a lot of waiver support coordinators that don't understand why the auth is so important to them. The main thing that it does for you is it allows you to ensure that the providers you are helping your clients to choose can meet their needs. If a client needs meds, the residential provider has to have validated medication assistant providers there working around the clock to give them to them. If a client goes to a day activity like an ADT and they need a noon medication and they cannot give it to themselves, then they must have an MAP, a medication assistance provider there. If the client needs medication assistance and is fed through a G-tube, The waiver support coordinator really has to make sure that any of the unlicensed service providers working with the client are medication assistance providers who've had further training and validation in prescribed enteral formula administration. You can't place somebody somewhere where the people that work there do not have the tools to meet their needs. There are exceptions. Family and friends who assist a client with medications without compensation, they don't have to meet the rule requirements. And most especially, and most confusingly for many, if a client lives in an ALF, 65G7 does not apply. There is no auth, there is no anything else, because the medication administration in an ALF is governed by ACA. However, if that client living in that ALF governed by ACA goes to a day activity provided outside of the ALF by one of our providers, 65G7 does apply while they are at the day activity. Next slide. Okay. As you saw on that form, and we'll see when you download it, there are 5 levels of ability. And I'm just going to read right through these with a little description after each one. Many clients are fully capable of self-administering medication without supervision. These clients handle their own medications. They take them without prompting, and nobody keeps any medication administration type record on them as to whether they have taken them or not taken them. If they live in a group home, they do need to keep them locked within their room. They may have help. They may choose to get them locked up with everybody else's meds, but they just ask staff to bring them their meds in that case. And staff can remind these clients. They can say, hey, John, it's time to take your meds, but there's no requirement for it, but they can. And they can help them order them and get them, delivered from the pharmacy and things like that. But these clients handle their own meds. They open the bottles, they open the bubbles, they do, and they keep track of the time when they're supposed to take them and everything else. The client who's fully capable of self-administering medication does not have to sign an informed consent because nobody is administering medication to them. The client that requires supervision while self-administering medication, that client is trying to move towards more independence with medication administration and may eventually be capable of self-administering without supervision. But right now they need help. People with difficulties with opening bottles and things like that often fall in this category as well, because they need somebody to open the bottles, get the pills out, and all of those things. But they can tell them what the pills are for or what medication they need at any particular time. Sometimes they cannot. This is a spot where our clients can move towards independence. These clients do have to have their meds centrally stored and locked up, and they also do have a medication administration record kept for them because the people that are helping them have to document what they do. The third category requires medication administration assistance, and that is when the client does not do anything for themselves in terms of medication administration. They just take the meds they are given. That does not mean we cannot be moving towards independence with these clients. We can, and we should be, but they do require total assistance with medication administration. And their meds also, of course, are locked up, and an MAR, a medication administration record, is kept on them. The last 2 categories are the same as the first 2 categories, which are self-administration without supervision and self-administration with supervision. And in both of those cases, we are, excuse me, I'm sorry, let me go backwards. I just said that wrong. It's requires supervision while self-administering medication and the ones that require complete assistance. In both of those cases, there may be medications that the doctor says this person can administer this by themselves without supervision. I know that sounds really confusing, but what is happening here is that the client may have, say, an albuterol inhaler for asthma. Those are commonly called rescue inhalers. If the client knows how to use a rescue inhaler and understands when to use it, because it is a drug that they have a stimulus that makes them feel like they need to use it and they're used to using it, then if they can be, if we think they can do that, we will let them take their rescue inhaler with them, because a rescue inhaler locked up in the group home does not do you any good when you're traveling in a car and you have an asthma attack. So there are several types of drugs that, you know, if they can be independent with those, in some cases it's things like creams and lotions. Any independence that we can give our clients is great. So the doctor may say that there are things like this. Another place where they'll use this is, we do have many clients that if given a preset insulin pen, can give themselves a regularly dosed dose of insulin. And because unlicensed staff cannot give injections, it's really helpful if we can do that. So that's one other place. Okay, next slide. Okay. As you're thinking about whether a group home with MAPs, medication assistance providers, can help you do everything your client needs, you need to know that the rule says that there are several routes of medications that aren't allowed for MAPs. MAPs cannot do vaginal medications, although they can apply medication to the perineum. They can't give injections, insulins or shot, any other kind of shot they can't give. Do please note that EpiPens used in an emergency are allowed without validation. They need to be shown how to use them and such, and the curriculum for MAPs does cover EpiPens, and those are accepted because that's an emergency thing. MAPs can't use IV meds. They can't give medications through tracheostomies, and they cannot give medications through a nasogastric tube, anything going in through the nose, or any G-tubes that are connected to suction or venting. If your client needs meds through those routes, you're going to have to request the appropriate type of nursing, skilled, residential, or private duty, and with the correct number of hours to meet the client's needs for those meds. Next slide.
Lori,
there's a poll question. Yes, you have a poll question. Sorry.
A poll question.
Excellent.
So this poll question that you should be seeing up on your screen is asking, if you have a client fed through a tube, can they have nursing services? So go ahead, take a few moments. Okay, thank you everyone. I'm going to go ahead and close it and share our results. So Lori, do you have any comments about these poll results?
Same comment I had from the last ones. I'm really glad y'all are here today.
Okay, so next slide.
If your client is fed through a tube, they don't automatically get nursing anymore. Not at all. That was a memo that was sent out some time ago, but when 65G7 was adopted on July 1st, it made it kind of moot. It superseded the memo, and they say the legal language for that is it superseded the memo from Denise Arnold on the subject, which was automatically rescinded as an operation of law. Now with 65G7, we do have a legal framework to assure that unlicensed providers are trained and validated on prescribed enteral formula administration, which we call PFA for short. You'll hear that a lot. PIFA training is available statewide from APD approved trainers using an approved curriculum provided by APD. So if you have a client that has just regular tube feeding, there's very few exceptions to this actually. Any client with tube feeding most likely will need to be fed by unlicensed staff and would not qualify for nursing. Next slide. I think there was a, is there? No, that's where we were going to do the next poll question. I just figured it out, Elizabeth.
Do you
Okay.
remember the question?
No, I don't. Well, I
Okay.
sort of remember it, but I'll just wrap it in here. The MAR is the medication administration record. We've given you a copy of it. This is a real valuable resource for you. And all of the medications a client receives are listed on that MAR, or they are supposed to be. The MAPs document on the MAR when they're given, but they also document on there when and why they are not given. And by becoming familiar with reading and interpreting the MAR, you can easily tell if your client is missing medications or taking as needed medication really often, you know, the meds that they need for headache or whatever. You can see they might take it a lot, and that might be something you would want to address, or it would be something that they could be refusing a lot. If you have a client who is refusing a lot, you may want to think about a behavioral assessment or a discussion with the legal representative, which may be the client, and the doctor about the medication regimen, because clients refuse for any number of reasons, and I'm sure many of you have had medications prescribed that you just decided not to take after you took them for a little bit. Well, our clients are the same way, and we need to talk to the doctors about that when that happens. And if it's a behavioral issue, you may want to consider a behavioral assessment. Okay, next slide. Okay. APD has people that can help you as you navigate through medication and medical issues. So when should you call them? When should you call your medical case manager or the clinical stream lead for your region? You can call them when the client might need nursing and you're not sure what to ask for. You could call them if the client or family choice of living arrangement doesn't meet their level of medical necessity. They would then involve other people, but you know, that's a good place to start. You could call them and say, hey, my client really thinks they'd like to go to XYZ group home. Do you think they can meet their medication needs? And tell them what their medication needs are. They can do the same for an ADT. They can talk to you about anything about health and safety. You can get technical assistance with group home providers and with monitors. You'll definitely want to reach out to them at times when you're working on a SANS or a crisis. If you have questions about medical necessity, and I'm sure Claire's going to talk more about this, help with DME or CME. Anytime one of your clients dies, you are supposed to be submitting a report of death in iConnect, working on that anyway. You can get answers to your questions there from your MCMs. And any assistance you need with medication administration questions and PIFA, your MCMs are the people to go to because they're the subject matter experts on that. Okay, next slide. Okay, a few things I wanted to cover really quickly for you because my time is going by fast here. Suctioning. I know you sometimes see that your client will need suctioning. Unlicensed staff can do suctioning as long as it's oral or nasal suctioning to manage secretions. It's not considered deep and is most often done using something that looks a lot like that, which we call a yanker. It's very similar to what's used at the dentist's office, and it's only meant to be used in the oral cavity or just inside the nose. It's too large and it's too stiff to be used in the nasal cavity high up or deep in the throat. Deep suctioning of the nasopharynx, oropharynx, or trachea, including through a tracheostomy, is done with a long, thin, and flexible tube, and it may not be done by unlicensed staff as it is an invasive procedure. So when you are looking at a client that they say has suctioning, one of the things we get so much is they say they need a nurse because they have suctioning. And when we investigate, they're being suctioned because they drool with a yanker. That doesn't take a nurse. Okay, next slide. There's also a lot of confusion around ostomy bags and catheter bags. Unlicensed staff can empty ostomy bags of all types once they're trained. They can also be trained to change an ostomy wafer by a nurse, because you know those wafers do come unstuck when there's no nurse available to change it. The client with an ostomy needs regular skilled nursing visits to change the ostomy wafer and assess the condition of the stoma and the surrounding skin. These visits, of course, would be more frequent with a new ostomy. And then as time goes on and the ostomy matures, that nursing visit would be less frequent, but they're gonna still need it some. And unlicensed staff can empty and change urinary catheter bags and provide catheter care with appropriate training. And that is for any catheter, a suprapubic catheter, a urinary catheter, or even a nephrostomy tube leading to a urinary bag. They can deal with the bags. Okay, next slide. There are things that unlicensed staff may not do. They can't change the G-tube. If it falls out, somebody else has to put it back in. They can't do anything with a tracheostomy, with the suction or anything like that. They can't insert a urinary catheter. Again, they can't do injections, including insulins or IV. They can't do wound care, except for cleaning and covering superficial wounds. If it's a wound care order, have trouble knowing if it's a wound care order or a superficial wound, that's one place to talk to your MCM. They can't do manual bowel disimpactions, and they can't take care of ventilators. MAPs, however, may do AccuChecks for blood sugar readings as long as it is not associated with the administration of insulin. And that's a very common question we get. Okay, that's it for me.
So Lori, before we move on, a few questions came into the chat box, and I thought, it might be wise to address them now rather than at the end.
Okay.
And so the general question that came in from a few different support coordinators is the AMA required in a family home or independent living or supported living environments?
If you have staff there giving the person medication, yes.
Okay.
If the person is, you have to, the only way we know, let me rephrase that. The only way we know if a client is capable of self-administering medications while we have paid providers serving them is if that is filled out. So if any client that has a provision of services, no matter what the environment, if they're in their family home, but you have a companion in there, or you got personal services in there, or whatever, and that client, you need to know, because the person who gives the meds has to be qualified to do it. And so you do need to know for all clients what their level of ability is.
Great. I also would like to just remind everyone that if you have questions about this after the fact, like after this training, you can reach out, as Lori said, to the regions and to your MCMs to get more details about your specific situation and see what it is that needs to be documented and how.
Correct. Please do.
So next up on our agenda is Claire Davis, and she is here with us to speak about nursing services. So Claire.
Okay, hello. My name is Claire Davis. I'm a registered nurse and I review state office SANS requests. The majority of the SANS that I review include nursing services. Next slide, please. Waiver will fund private duty, residential, and skilled nursing under certain circumstances. As you can see under resources, Waiver is the payer of last resort. Natural and community supports, third-party payers, for example, private insurance, Medicare, and other Medicaid programs such as Medicaid state plan or Medicaid managed care plans have to be accessed prior to accessing waiver services. Keep in mind that medical necessity for the service must be established in order for waiver to fund the service. Each time a service is renewed or requested, whether it's increased or stays the same, medical necessity has to be determined. A medical necessity review is done to determine if the service or level of service being requested is still necessary and consistent with the definition of the service in the handbook. Just because the service has been ordered by the physician does not in itself make the service medically necessary. Next slide, please. So private duty nursing through the waiver is limited to recipients aged 21 years or older. Emphasis is placed upon the fact that the nurse is providing active interventions on a continuous basis for over 2 consecutive hours per episode, not intermittently providing services. These services are primarily provided in the recipient's own home or in the community when the recipient is engaged in a community activity. PDN is not used for ongoing medical oversight or monitoring of direct care staff or caregivers. Next slide, please. Residential nursing through the waiver is also limited to recipients aged 21 years or older. Emphasis again being placed upon the fact that the nurse is providing active interventions on a continuous basis for over 2 consecutive hours per episode and not intermittently providing services. These services are primarily provided to recipients that are residing in a licensed residential facility or residents of a residential facility when engaged in a community activity. Residential nursing is not used for ongoing medical oversight or monitoring either. Next slide, please. Skilled nursing is for intermittent services. These services are primarily provided in the recipient's place of residence, whether it be their individual home or licensed facility, and at other waiver service sites such as an ADT. Skilled nursing is not used for ongoing medical oversight or monitoring of direct care staff or caregivers. This service is for interventions that can be accomplished at intervals for the length of time necessary to complete the services. Next slide, please. Through state plan, private duty nursing and personal care services are for recipients under the age of 21 years. Skilled nursing visits are provided through state plan to recipients aged 21 years and older. This service is provided in the recipient's place of residence or in the community. Skilled nursing visits through Medicaid state plan are provided at intervals for the length of time necessary to complete the service. Since Medicaid state plan or managed care plans cover up to 3 intermittent visits for recipients aged 21 years and older, these services have to be accessed prior to accessing waiver services. Next slide, please. State plan can cover many services through intermittent visits, for example, catheterizations, injections, IV fluid administration, IV meds, wound care, insulin injections, G-tube changes, urostomy bag changes, bowel disimpactions. If the visits are required more than 3 times per day, After exhausting the 3 visits through state plan and managed care plans, the waiver can cover the medically necessary services that exceed the Medicaid state plan limit. Next slide, please. Some services cannot be completed as an intermittent visit and may require coverage through the waiver. For example, a recipient who is ventilator dependent, who is tracheostomy dependent for an airway, who requires frequent deep suctioning such as pharyngeal or nasal pharyngeal. A recipient who has a central line that requires more than intermittent manipulation may require coverage through the waiver. Next slide, please. Personal support services provides assistance and training to the recipient in activities of daily living, excuse me, such as eating, bathing, dressing, personal hygiene, and preparation of meals. This service can include supervision, and when specified in the support plan, this service can support a goal or an identified need to support or maintain basic health and safety. This service is not purely diversional in nature. Next slide, please. An authorization for trained personal supports is for personal supports providers that have completed the medication administration and enteral feeding training. Providers that are trained in accordance with Rule 65G that are not otherwise licensed to administer medication can administer medication, and effective July 2019, these providers can also deliver enteral feedings. These providers can administer medications by various routes, as you can see on the slide. The regional office medical case manager can assist with a list of available trainers for providers that need subsequent validations, and a provider of choice can also obtain initial validation. Next slide, please. In accordance with Rule 59G-1.010 Florida Administrative Code, the medical or allied care, goods, or services furnished or ordered must be reflective of the level of service that can be safely furnished and for which no equally effective and more conservative or less costly treatment is available statewide. The fact that a provider has prescribed, recommended, or approved medical or allied care, goods, or services does not in itself make such care, goods, or services medically necessary or a medical necessity or a covered service. So if Rule 65G-7 reflects the level of service, such as through trained personal supports or a MAP, that can be safely furnished, is equally effective and more conservative or less costly to provide the necessary care that the recipient needs, and training is available statewide, then trained personal supports is approved or a MAP provider is considered in the RES-HAB level determination. By trained personal supports, it means a personal supports authorization is rendered for a personal supports provider that is trained in accordance with Rule 65G-7. And if the recipient resides in a group home, excuse me, the approval takes into consideration that a MAP provider, which is a provider trained in accordance with Rule 65G-7, can cover G2 feedings and medication administration. And this is reflected in the RES-HAB level determination. Next slide, please. The documentation that is submitted must substantiate what is being requested. This documentation is reviewed to gather a picture of what is actually occurring during the course of the care for the recipient. So the most current nursing care plan, daily progress notes for the past 3 months, the most current nursing assessment, a monthly summary of the recipient's health status, the current prescription for the service, the list of duties that the nurse is expected to perform, and other relevant documentation must substantiate the medical necessity of the services that are being requested for this recipient. Next slide, please. The SAN services authorization takes into consideration the required actions or interventions during seizure episodes. When is oxygen required and used? When is post-ox monitoring provided? What are the average results? What are the suctioning requirements? What is abnormal and requires a nurse's interventions? Next slide, please. This is an excerpt of what I believe to be an excellent MCM report. I like the way the MCM reviewed and summarized the nursing notes and identified what was documented in the nursing notes, such as vital signs were taken with no abnormal findings, assessment of body with no abnormal findings. Between April 30th and July 31st, recipient experienced 15 seizures lasting from 12 to 22 seconds. No interventions were required. There were no documented issues in the nurse's notes indicating problems with the G-tube site or feedings. Also, she documented that there was no documentation in the nurse's notes indicated that the recipient required the use of oxygen due to low O2 saturation levels or respiratory issues. If there are no interventions that are being required of the nurse, then you have to consider if nursing services would need to be requested. Next slide, please. I like the way the MCM quoted the justification for her determination. And then she provided a recommendation for services without recommending a specific number of hours. She included a recommendation for a provider from our Rule 65G-7, and she included Medicaid state plan services coverage prior to accessing waiver services. Detail is very important, which helps state plan make a determination on the number of hours required. Next slide, please. So, okay, let's try a few scenarios. So during this exercise, we are talking about waiver services. In scenario one, I think this is set up as a poll question. Is it, Elizabeth?
Yes, it is.
Okay, so this is scenario one. The individual lives in a group home, has a tracheostomy requiring suctioning every 3 hours, is ventilator dependent, and has a central line requiring every 4-hour medications and flushes. Which waiver service would be requested? The
So,
four options are,
go ahead, Cliff.
okay, the four options are PDN, personal supports authorization for a provider that is trained in accordance with Rule 65G-7, residential nursing, or a MAP provider would be considered in the RES-HAB level determination.
So by now you should have your poll question up on your screen. Go ahead and make your selection. Okay, it looks like most of you have voted. So I'm going to go ahead and close and share.
Okay, so we're looking at that the recipient lives in a group home. So that's one of the clues. And this would be residential nursing because they have a trach, they're ventilator dependent, and they have that central line that requires every 4-hour medications and flushes. Okay. Next slide. This is scenario two, and the individual lives in a group home, has a G-tube and is fed via a pump at 50 cc's per hour from 7 a.m. to 7 p.m. daily, and has enteral and topical medications. Which waiver service would be requested? We have the same options. Okay, was that enough time, Elizabeth?
Yeah, that was great.
Okay, so this person lives in a group home. So the MAP provider that's trained in accordance with Rule 65G-7 will be considered in the RESHAB level determination. So RESHAB level considers MAP provider in the determination for this one. Okay, next slide. Scenario 3, the individual lives at home with elderly parents. The individual lives at home with elderly parents, has a tracheostomy requiring suctioning every 3 hours, is ventilator dependent, and has a central line requiring daily medications and flushes. Which waiver service would be requested? And we still have the same options to choose from. Okay, so the key to this is, one of the keys is the individual lives at home with elderly parents. Um, and this individual has a tracheostomy that requires the suctioning every 3 hours, has a ventilator and a central line that requires daily medications and flushes. This would be private duty nursing. Okay, and our final scenario, number 4, the individual lives in the family home, has a G-tube, and is fed via a pump at 50 cc's per hour from 7 a.m. to 7 p.m. daily, and has enteral and topical medications. Which waiver service would be requested? And we have the same 4 options.
Sorry guys, I accidentally launched the poll too quickly, so your selections won't be available. So go ahead and
Okay,
put your what you think it is in the chat box. If it is private duty nursing, trained personal support provider, residential nursing, or ResHab level considering the MAP provider. So Claire, it looks like we're getting a lot of people with trained personal supports. We've got some people chiming in with PDN. But it looks like the vast majority is saying trained personal supports.
okay. We're looking at this, that the recipient lives in the family home, and then we have that G-tube feeding, and those medications that can be provided by a trained personal supports provider that's trained in accordance with Rule 65G-7. So it's the personal supports authorization for a provider that's trained in accordance with the Rule 65G-7, which is synonymous with a MAP provider. And that's it for me.
Great. Okay, well that's perfect timing for everyone. We have a little bit of extra time where we can address some of the questions that have come in. over the course of the presentation. So for those who have not sent their questions in, go ahead and send those in. I am going to go through the chat box. There might be a few moments of silence, and that's just because I'm reading. So just bear with us as we go through some of these. Okay, so we had a few questions come in regarding CDC employees and how they, the question is, do families who are CDC employees have to be validated in order to feed consumers by G or J tubes? And very similar question, but regarding medications, do they have to be validated to give medications?
We asked our legal department, this is Lori, that very same question, and the answer is yes.
Great. We have a few definition questions. Can you define ongoing medical monitoring? And can you, how are skilled nursing intermittent visits provided to a family home under age 21?
Can you say that last part again?
Yes. How are the skilled nursing intermittent visits provided to a family home under age 21?
Oh, when the recipients are under age 21, then they are covered through Medicaid state plan. State plan covers private duty nursing and personal care services for recipients under 21 up to 24 hours per day. And if they don't require continuous nursing and they just require the intermittent visits, then they can get up to 4 intermittent visits per day, but that's through Medicaid state plan.
Okay. And can you define ongoing medical monitoring?
Sometimes the recipients need monitoring of their care to kind of monitor and see if something else needs to be done or if something needs to be changed. The physician is really supposed to be in charge of the recipient's care. The physician is supposed to be um, monitoring and directing the services. So that wouldn't be something that would be put in the hands of a nurse to be providing monitoring to see if something's going to happen or change, or that's the physician does the ongoing medical monitoring.
Okay. What is the difference between private duty nursing and skilled nursing?
Okay, so if you're looking at state plan Medicaid and it's for recipients that are under 21 years old, that is considered private duty nursing for recipients that are under 21 years old. State plan calls private duty nursing continuous nursing, but it's only for their recipients that are under 21. Now, once a recipient turns 21, the waiver still calls it private duty nursing, and it's continuous nursing for more than 2 consecutive hours per episode. But state plan no longer calls it private duty nursing if the recipient is 21 and older. They call it state plan visits. They're no longer eligible for private duty nursing once they turn 21 under state plan. They are only eligible for intermittent nursing visits, up to 3 visits per day. But the waiver covers the private duty nursing for recipients 21 and older. It's called private duty nursing for recipients 21 and older through the waiver. I hope I wasn't confusing with that.
Okay, Lori, I think this question is for you. The client is living in the family home and mom is monitoring the medication. Do they have to write on the MAR?
No, Rule 65.7 does not cover families. However, if you have people in the home that are using the MAR, because if mom is monitoring the medications, that's one thing. If mom is giving them, that's something else. If there are people in the home that are required to document on the MAR because they are MAPs, then it would be very helpful if the rest of the family who are giving medications in their capacity as family members when we don't have, MAPs or other staff in the home would also do so, so you'd have a nice complete picture of the meds that were given, but they're not required to.
Okay, great. Okay, so we're getting very close to our 11 o'clock time, but we do still have a large amount of questions that have been coming in. So what I'm going to do is collect all of the questions, get it organized, and then I will send them to Lori and Claire for response. And once that is, once I receive it and get it put into like an FAQ type format, I will put these up on the website. So in the next couple of minutes, go ahead, keep sending your questions in. We won't address them right now, but just so that I can have them for later. And I just wanted to say thank you to Lori and to Claire and all of you for joining. I found the presentation extremely helpful. I know I learned a lot, so I'm sure that you all learned a lot as well.